Dr. Jayanth Sampath, Senior Consultant Pediatric Orthopedic Surgery, who will be moderating today's session. Dr. Sampath brings extensive expertise in children orthopedic care, and we are fortunate to have him guide our session.
Good evening, everyone. And it's great to have Professor Kishore Mulpuri with us on the event of World Cerebral Palsy Day. It was inspiring to see all the high achievers starting off the meeting, and it gives us great pleasure as clinicians to see that as adults, individuals with cerebral palsy can reach great heights and make a significant contribution to society. So I think it's a fantastic start to this evening. Homegrown and started his orthopedic education under the illustrious Professor Benjamin Joseph in Manipal. He published one of the seminal papers even as a trainee on a condition called Perthes disease, which to this day is a very widely quoted piece of research work. And then he built on it by successive fellowships in Australia and eventually settled down in Vancouver, where he has been for the last 23 years. His achievements are really too many to list. Briefly, he was president of the Canadian Orthopedic Association, the first Indian to take this prestigious post, and also founder president of the Canadian Pediatric Orthopedic Group. He has been in close touch with the Pediatric Orthopedic Society of India. Many young pediatric orthopedic surgeons have benefited from the fellowship opportunities that Professor Kishore created, I think 5 years ago. And many of us are extremely grateful to him for the amount of work he has done in association with pediatric orthopedics in India. He's also a leading light in terms of research in CP hip surveillance, and he was instrumental in creating the Indian guidelines for hip surveillance in cerebral palsy. So it gives me really great pleasure, and it's an honor to introduce our speaker for today, Professor Kishore Mulpuri, to talk to us about a topic that I'm sure is close to his heart, which is hip surveillance in cerebral palsy. Over to you, Kishore.
Thank you, Jay, for that very kind introduction. And
Would you stop presenting?
Those of you that probably have not met Jay, Jay himself is an incredibly inspiring person and someone that I respect quite a bit on the circuit. And it is actually one of the meetings that he organized in Bangalore that I had a good fortune of attending that meeting in 2015 that really sparked my real passion and interest for getting involved with POSI and everything else that followed. So Jay, you've been a huge part of my re-engagement back with India and the societies and doing the work. So grateful for that. And I agree with you, Jay, and it's very inspiring to see the patients that we take care of that become young adults and contributing immensely to the society. So congratulations to everyone that is on the call here, everyone that is not here that'll be watching down the road. And congratulations to Indian Academy of Cerebral Palsy for putting together, and all of the volunteers and patients and families that have actually organized this and gave me an opportunity. Can you see my slides?
Yes, yes.
Yes, good. So I want to share a little bit of my experience with taking care of children with cerebral palsy and how hip surveillance program has come about here in British Columbia, and how that's actually helped us to care for children with cerebral palsy here locally, but also globally, how we can all work together, learn from each other, and how we can improve care in our own settings. But working together, we can improve care around the world. These are my disclosures. I do work with industry, so I just want you all to be aware, but none relevant to this talk. And Jay mentioned briefly, this is my training. I went to medical school in Manipal. I worked with Dr. Benjamin Joseph. I did my orthopedic training there. I spent some time in Australia, and then I came to Vancouver to do a year of fellowship and come back to India and go to Vijayawada to practice, but never left. And the reason that this is important is a lot of what you will be hearing from me about philosophy of care is really what I picked up in all of these places, working with some legends of orthopedic surgeons. Specifically, when it comes to cerebral palsy, it's Dr. Benjamin Joseph in India and Dr. Kerr Graham in Australia, Melbourne, Australia, and Dr. Rick Beauchamp here in Vancouver. Three pioneering surgeons, and all have had their own gait labs in their countries, but all contributed immensely to my understanding and care of children with cerebral palsy. One important thing that I talk about whenever it comes to care of children and families with cerebral palsy is the 10 times 10 times 10. The most important 10 is patients and families, and the next important 10 is the team, that is, whether it's the nurses, physiotherapists, the community therapists, pediatricians that are involved. And the least important 10, as much as we, Jay, myself, as surgeons, we're megalomaniacs, we think we're God's gift to humankind, we're actually the least important 10. Any surgeon that is trained in children's orthopedics can perform the surgeries that me and Jay perform quite ably. It doesn't matter where in the world they are. But I think what's missing often is the most important 10, which is, do they have enough support in the community? Or is the family and the child ready and able to actually go through any major interventions that we as surgeons are going to propose? So if one of those 10 is missing, you only get 1/10 of it. So really understanding it's a teamwork that's really important when we care for these kids with cerebral palsy. So I want to start with the story of this young girl, Rachel. I finished my training. I mean, in India, believe it or not, in 1990s, Dr. Benjamin Joseph had a very well-organized clinic for cerebral palsy. I went to Australia, obviously it's top-notch. Kerr Graham had an incredible program. And I come to Vancouver here in Canada, I expected to follow the same. But this is what I was seeing. I was seeing young kids in wheelchairs in a lot of pain, and you get an x-ray, and their hip is dislocated completely, and the cartilage is gone. And then we were doing femoral excisions. And as you can see here, they develop a lot of new bone formation around that causes a lot of pain and discomfort, and they develop scoliosis, and it was a hard bit to deal with, especially knowing in Melbourne where they had a surveillance. These were caught quite early. This operation is quite rare. And this is what you see here. This is a femoral head. We chopped the femoral head off, and this is going into the bin. And that was very disheartening to see. I'm a surgeon. I'm trained to do reconstruction and save hips. There I was chopping a hip after hip. And I did in my first 5 years of practice about 15 to 17 femoral excision every year. And so that really brought and say we really needed a change. And when we started talking to people in our hospital, they're like, well, there is not a hip surveillance program in North America. There is not one at Sick Kids Toronto, and you're not going to have one, and it is not going to be approved. So we started really working and going and showing this data of how we're doing ours compared to Melbourne, where in Melbourne, as you can see, they were doing a lot more preventive strategies, reconstructive strategies, no salvage surgery. Whereas in British Columbia, more than a third of all the interventions I was doing in children with cerebral palsy was actually cutting the femoral heads and throwing them in the bin, which was incredibly disheartening. And anytime you're trying to have a system change, it's an uphill battle, and it's a losing battle is what you feel. And what I'm going to show you in the next little while is that it is worth that battle. It's worth making the change because the improvements that you make after that are incredibly gratifying. So what we then decided is we need a hip surveillance program, and a program that that is going to be really helping our children and our population. So the aim is to try to get people to refer to our clinic early on at an appropriate time. And all of that need to be based on clinical and radiological exam. And we needed to figure out at what frequency we're going to be able to do. So we managed to go and work with our ministry, our patient partners, and Cerebral Palsy Society here in British Columbia, and showed them that it is really important that we have our own surveillance program. And we gave them a lot of evidence of different programs that are out there in the world, and the evidence that it actually makes an improvement. And the way you go about doing that is serial x-rays, where you're measuring the percentage of the femoral head that's out of the socket compared to it's in the socket. You can see here on this side, 100% of the femoral head or the ball of the hip joint is out of the socket. And this is what happens. This is the same patient where if we saw this patient here, that patient would receive a very different intervention versus out here. So how do we identify patients here early on before they develop a deformity? And the reason we needed to do that is if you don't intervene early, they get pain, they reduce, they lose their range of motion, and you will have to end up doing more complex surgery. And how do we actually go about doing that? So most of you are probably familiar with this work of GMFCS classification, and it's really important. It's like learning alphabets when you're going to school. And the same way, if you do not understand this classification, then you really are not fit enough to care for children and families with cerebral palsy. Because this really gives us trajectories about what to expect, when something might happen, when you might need to do interventions, and that's no different for hip surveillance program. So those that are in a wheelchair that have less mobility are more likely to have hip problems. As you can see here in red, what that means is they have a hip subluxation of more than 40%, is way higher in GMFCS5. That is, these children that are in a wheelchair here, it's way higher in 4s, 5s, and 3s compared to 1s and 2s. So that gives us at what frequency and how we need to care for these kids. So before you plan any program, especially if you're planning a program of a province or a country, it's important to understand how your country or your province, that means your state, is set up, so you're able to do a population-based program. So this is the population, the area of British Columbia. It's 5.6 million population, 1 million square kilometers. So just to think of what Singapore is, that is 675 square kilometers, 25 kilometers by 25. In Vancouver, in this small part, will be more than 25 by 25. And it's a huge, huge province of only, about 65 lakh people or 55 lakh people living there, right? And so it is not a huge province, but geographically distributed. So someone to come from here to where the children's hospital is, out here where the star is, they're traveling about 20 to 22 hours by road to get here. It's almost in India from going from 4 different states to go somewhere else. So we needed to think about how do we design a program and who the key stakeholders are and what existing resources and strengths do we have to be able to do that. So then we realized we needed to really use all of these stars you see where the physiotherapists are, and these yellow stars is where physiotherapists are there in school. Once children are going to school age and they go to these areas, so we needed to partner with them. And then the big star that you see is where the red star is where the children's hospital is. And these blue stars you see is where the children's orthopedic surgeons are. So it's important for us to plan around existing resources. That's why whenever we plan any program, including the one we did in India, it's important for us to think about our setup and our area, our clinic, whatever you're doing, if it's a clinic based, you need to look at what are the strengths and who are the people that you have in your clinic to be able to set up your own program. So this lady you see here, Stacy Miller, and this lady you see here, Jennifer Farr, are the key important people that actually run our program. Stacy is actually the one, she's a physiotherapist. She's on the board of American Academy of Cerebral Palsy and Adult Medicine. She started working with me in 2009. By 2011 is where we got an approval saying that we could come up with a hip surveillance program. So we came up with these guidelines by bringing 50 people together. These are therapists, policymakers, surgeons, pediatricians, family doctors, and therapists all coming together to really come up with what our British Columbia guidelines will look like. In 2012, we mapped out a process, who would screen, how do we screen, what happens. And 2014 is when we formally hired these two individuals. 2015 is where an advisory committee got stuck. 2016, we onboarded 2 sites. So you can see the lag difference between I started in 2003 advocating for a program. 2011 is where something actually happened. And 2016 is when we formally rolled out the program. 2018, we tweaked the program again based on the lessons learned very slightly. And it's ongoing, and I'll tell you where we're at right now. And so what did we do? So we did a province-wide implementation, as I said, in 2016. And we said all children with cerebral palsy born from 2000 to present are going to be followed. Because we expected the children born in 2016 would be getting into their adulthood. They'd be 16 years old in 2016. So we needed to follow those kids and beyond. So now I'll probably go through what are the lessons that we learned. So one important way is for you to remember there is not one way. You don't want to blindly follow our guidelines in British Columbia or the guidelines from Melbourne or from Scotland or from Sweden or Norway. You needed to really look at your clinic, your setup, your state, your country, that is our country, India, and really think about what works based on how you're planning. And the reason that is everyone is set up very differently in different health systems. And so, but important considerations for that probably hold good for everyone is who will identify a child, who will complete the clinical exam at appropriate time, who will request radiographs, and who will measure the ramus migration percentage. With artificial intelligence, that you may have apps now that are able to probably measure on their own, but till we get to that stage, you will probably need to think about that. And who will coordinate this program? If it is in your clinic, it may be your clinic nurse, clinic receptionist, or if it's a state-based program, it may be somebody else. So, but it's really important to address that. These are 5 fundamental questions if you're planning your own program that you want to think about. So the other lesson is diagnosis is very important, and that will impact your enrollment. And a lot of the time, any surveillance program, and you will see, including India's, will tell you that we need to recruit these patients by as early as we can. The first X-ray we suggest is by 2 years of age. A lot of the time, these children are not diagnosed by 2 years of age. That impacts their enrollment into the program. So what we say now is we will enroll anyone that has either cerebral palsy or cerebral palsy-like conditions. If we need to exclude them later on, we will, but you rather over-include than exclude. So at enrollment, as you can see, even in our own program, only 64% were confirmed diagnosis. And at review of the diagnosis, later on, there was 80% of them. So, but still, there are a lot of them that are not confirmed, or there are some with time. It turned out they're actually not cerebral palsy, that we possibly don't need to have them in the surveillance program. So one key important message is really figuring out this other, and also looking at reviewing the department, your diagnosis, and some way of really estimating how many people are enrolled and how many people are possibly have that you have cerebral palsy. So it's really important. I mean, we're able to do that because we're a population-based or a state-based program, but it's important for you to be thinking about how many patients are expected to be in your program and how many patients do you have based on the population estimates, which again may differ from place to place, from clinic to clinic. And here, as you can see, we calculated based on our population estimates of cerebral palsy. We think that we're probably enrolling more than 94% of the expected people for our birth cohorts from 2010 to 2020. The other important thing is really the knowledge translation is very, very important. If you don't educate all the people that are involved and involve them actually in creating these education modules, you're not going to make any progress. So it's also important to understand there's a multidisciplinary team. If we just pediatricians get together and they talk to themselves, or we as pediatric orthopedic surgeons at POSI meeting or somewhere else talk to ourselves, it's not going to make any impact. We really need the therapists who see them more commonly than anybody else, and the primary care providers, whether it is general practitioners or pediatricians. In the way India is set up, even OBGYNs that are involved in the delivery and sometimes care for those families longer, we need all of them involved. And we need knowledge translation efforts that involves families. In India, as you can imagine, the number of different languages we have, translation into those and others. So really need to take a look at that. So what we did is we came up with this parent booklets, and we had them in 6 different languages. We're continuing to improve and move those. We had a separate clinician booklet. We had an e-learning module with frequently learned questions. We have a website. We have a quick guide. So it's so important to have these. Otherwise, people, it's very difficult to engage with them. And this knowledge translation module that we developed actually won an award at ASCPDM for really educating people about, what is building consensus, what needs to happen, what is discharge criteria. And this module is something that a lot of our patients as well as providers access. And it's important to build your own based on your context. And so this is what our website looks like. If you go there, there's a lot of information. And I'm happy to share this presentation later on with Dr. Mallikarjun so he can forward it to all of you, but also happy to share some of these educational resources. And what came out of that is really some comments from our therapists along the province saying that how important this is and how helpful this is to have these modules. And so as I've said, I mean, when you go through the modules, they have descriptions about what is migration percentage, how is it measured, what would a fully dislocated hip looks like, and what would happen if the hips are dislocated. So families are well informed. If they're thinking, why does my child need an x-ray every 6 months or a year, they actually have some way to understand this. And the providers across the province, some way to educate them. And the other important thing is when we rely purely on radiologists to report, that might not be sufficient because our radiologists, when they're looking at it, they will simply say that hip is dislocated. They will not be reporting on ramus migration percentage because they're busy, they don't have time, and they're not necessarily trained to be looking at what we need to look at. So it's really important if you're a physiotherapist, a pediatrician, or a family doctor involved in the care of these people, or a developmental pediatrician, you know that you're able to look at that. So when we looked at our own hospital that leads the hip surveillance program, you can see that that a lot of them did not have any ramus migration percentage reported. So that is a problem where if you're a family doctor, a pediatrician, and you're expecting a radiologist to report it, they're not going to. So you need to learn how to measure. As I said, there are now some quick and easy ways that you're able to actually do the measurements. So 46 radiographs from community resulted in a referral to orthopedics. And as I talked about, not many of them have actually reported. Like say, for example, this hip was reported as normal, and it is not normal that both those hips are subluxed, especially the right more than the left. And so you really need to pay attention to these and have some way that you've learned how to do the measurement of hip subluxation. As I talked about, there are now these apps. There's a hip screen app. You can simply take a picture of that X-ray, and it will tell you how much migration percentage there is. And the other important thing, as you know, with these patients, they have a lot of other X-rays that are done. So you don't need to necessarily look and say, oh, there's not a dedicated hip X-ray. So here are all the examples. Sometimes they have an X-ray for some other reason. A pediatrician want to look at what's going on in their tummy if they have bowel issues. That X-ray is good enough for you to be able to see what's going on with the hips. Sometimes they get a chest X-ray or a scoliosis X-ray that includes hips, and that's good enough. So there is no reason to subject them to additional radiation. So before you routinely order X-rays, you should look at, are there alternate images that are done between the time you've ordered a hip surveillance X-ray to where you're at right now. So we, again, really look at and go through and see if there are other X-rays. Now, did the surveillance program actually change our surgical practice? I think this is really, really important. So in my first 5 years, as I said, a number of those children went on to actually receiving a salvage surgery. But within our first 5 years of our program, very few children actually came with dislocations, and majority of them are new to our province. And if you see here, what is the impact of a talk like this today? What is the impact of you being involved and wanting to learn and wanting to advocate for? So if you go back to the original timeline I talked about, 2008 to 9, we started talking about a hip surveillance program. 2014, we haven't even launched yet, but we developed the consensus program. We got our physiotherapists across the province involved. They came to know the importance of hip surveillance program, just like the way you're listening to this talk now. We have dramatically reduced the late presenting hips because people are aware this is, if I'm in a wheelchair, I have a 90% chance of my hips being, having some form of subluxation that needs monitoring. And that led to early referral to an orthopedic surgeon, dramatically reduced the need for a salvage surgery. And after, this is basically the effort of knowledge translation I'm talking about. After we implemented the program, 10 years later, you can see we have less than 2% of the hips now. And that 2% is either people that are known to us, medically very complex, families didn't want to go through it, or these are new to our province and they've come from another province where they don't have a surveillance program. Because we still are the only program in the United States and Canada that is statewide to have a hip surveillance program. There are lots of clinic-based programs, but not one that is province-wide. So what are the other benefits that you get? Is the hip surveillance program only for hips? Absolutely not. And you can see some of the comments that we get from our community orthopedic surgeons and the community physiotherapist, because it gave them an opportunity to track their own patients longitudinally, not just for hips, for other things. So I think this is something that we really need to keep in mind. There are lots of benefits where it improved our communication with our therapist, our family doctors, pediatricians. It really brought all of our orthopedic surgeons in our state that look after kids with children. There are a number of other projects now that we work through because of a program like this. And the other side benefit that happened when COVID-19 hit, our province knew that these children with cerebral palsy are one of the high risk to develop infection. So they wanted to be able to track them. And we were able to actually provide that data for them. So we suspended our program of bringing people into the hospital in 2020. In 2020 June, we were able to prioritize those that were high risk for progression. And they also used this data to be able to invite those kids to have vaccine and vaccine prioritization. And this also helps us with a registry. So Cerebral Palsy registry actually relies on a hip surveillance program to really track these people to see what other interventions they need. And this also gave us an opportunity to improve clinical care, work with our partners around the province, but also on some research. So the side benefits are huge, where we're able to really close this loop between research collaboration, clinical collaboration with our hip surveillance program. And we managed to contribute to the literature 14 different studies and manuscripts that are improving care, not just here in British Columbia, but across the world. So what lessons have we learned? So adapt your guidelines based on your clinic setting. Don't wait for somebody to tell you. You can start in your own clinic, in your own setup, in your own hospital now. And you don't need to think that I don't have a statewide program. If you have, that's great. But you can start in your own clinic now, educating people within your own city, within your own region. Knowledge translation is key. Educate, educate, educate. That's why I'm humbled and honored that you've invited me today to share our experience here of this program. So for implementation, as I said, do not wait. You can start now. You don't need to wait for, I cannot stress on it. You don't need to wait and say, we don't have a statewide program, or we don't have a countrywide program. We don't have a program in India as yet, but you can start in your own clinic with your own patient population now. And what is it that we don't know yet? We still have not figured out really about few things that I'm going to talk to you in the next few slides. Here is one example of a child with a GMFCS2. Typically at age 10, we say we can discharge them. And we know asymmetric diplegias are a different beast. So this child was asymmetric di. As per the hip surveillance guidelines, even though there was a mild dysplasia, the patient was at age 10, thought to be quite stable. That hasn't changed much over the last 5 years. The patient was discharged at 11 years from the hip surveillance program, comes back at 16 years with a loss of cartilage. So we figured that asymmetric dies are different. They behave like a type 4 hemiplegic cerebral palsy. So they probably need to be followed a lot longer. So if you see someone with asymmetric diplegia, you need to follow them. The other thing that we are beginning to realize is what are the drivers of continued hip displacement after reconstructive surgery? It is really the windswept deformity, as we all know, or if they have a lot of internal rotation, that means they sit in W, or they sit in a frog position. All of those three can actually make those hips go out, either in the front or out at the back. So it's important to really understand the knees can drive the hips. So after hip surgery, you still need to pay a lot of attention to knee contractures. If they develop knee contractures, these are the only three positions they can lie down in. So make sure you're paying attention to knee contractures and also scoliosis. Lots of different guidelines there are around the world. And you do not need in India to wait for other guidelines. And I can share with you that we have our own guidelines in India. So we helped ASC-PDM develop their own guidelines from BC, and it was led by our physiotherapist, Stacey Miller. And we also helped POSNA, Pediatric Orthopedic Society of North America, develop their own guidelines. And when you look at that, helping ASC-PDM or POSNA, Pediatric Orthopedic Society of North America, look at the population of US and compare to India and China. And this is where probably midlife happened to me. And around the same time that I came to visit Jay in 2015 in India, it dawned on me that if I'm thinking I'm doing some impact around the world, really my research and my efforts were relevant to less than 7% of the world. And that's actually what got me re-engaged back with India and with POSI. And what we did during pandemic is we developed two care pathways, one for DDH and one for cerebral palsy. Some of you that I see on the screen were involved in this. And these are 8 national organizations for cerebral palsy, representing over 100,000 healthcare professionals, 7 organizations for DDH, representing over 120,000 health professionals. And we came up with a care pathway, and this is the Indian care pathway, a national cerebral palsy hip surveillance program, which I know Indian Academy of Cerebral Palsy was involved. And as you can see here, this guidance was developed with keeping Indian context in mind. And what you should do, though, is modify it for your own clinic based on how your clinic is set up, when they come for follow-up, and when you're able to do that. But what's common in all of the guidelines around the world, GMFC has 4s and 5s and 3s. You have a very different follow-up compared to 1s and 2s. And then POSI followed that up by dedicating a whole mid-year meeting about how do we actually implement this in India. And I'm happy to share that UNICEF is now taken on for DDH to raise awareness and implement that. I'm hoping, I'm still working with UNICEF in India, that we could make a similar effort working with Indian Academy of Cerebral Palsy for cerebral palsy hip surveillance program. So I always say we have a lot to learn from each other. The efforts that we did with India on the DDH care pathway, we're actually building our own here in Canada. And the Indian care pathway were led by Dr. Dhiren Ginjwala for cerebral palsy and Dr. Elric Aruges for DDH. And the lessons we learned from them, we actually brought it back to BC, either in our implementation or our own program. And that's what I refer to as glocalization, which is local to global, back to local. And so in summary, diagnosis can impact a hip surveillance program. Knowledge translation is the key. And think about using alternate images. Don't order X-ray without seeing what X-rays are already available from the last visit. Standardized positioning is really important. There is no one right way. Figure out what works for you in your program. And time to start hip surveillance program is now. Do not wait. And I would like to end by why I get involved globally in all of this is because I'm selfish. I want to look at myself in the mirror, feel good about who I am. Those of you that are doctors that are here, we get paid really well, hopefully, for what we do. Hopefully, we're also good at what we do. That gives our profession. If you really enjoy what we do, that gives a passion. But doing things like developing a hip surveillance program where you're not getting paid anymore, or learning the knowledge and applying to our patients, we're not going to get paid anymore. But what it gives is our mission and vocation. And the sweet spot in the middle, if you're doing all of these 4, is the Japanese term, the reason for being, called ikigai. And certainly for me, I feel blessed to be doing what I do. And I feel blessed to have this opportunity to interact with you, share my knowledge, and learn from you. And if you ever want to know the work we do, is a QR code for our lab. And I will share this presentation. I'll put my email in the chat. Feel free to reach out to me. And I'm happy to work with all of you. Thank you.
Thank you so much, Kishore. That was really eye-opening. I'm so glad that this was not a medical talk, rather a talk that gets to the meat of how to implement a hip surveillance program. And you mentioned things like knowledge translation, team approach, and community-based implementation, which are the most important things, because I think the scientific part of hip surveillance has been more or less worked out. We know how to surveil hips, but then implementing it in a country as large as India is always a challenge. But it's good to know that there are so many side benefits to this, that
Yes.
Just implementing a hip surveillance program is just going to improve the overall care of a child with cerebral palsy and not just the hip. What are your ideas? I mean, you are part Indian, part Canadian now, but I think your heart is close to your roots. What are your ideas for starting a hip surveillance? I know you mentioned that just make a start. In your own practice, just start surveilling hips. But to take it to that next step, what should we be doing? What are the simple practical things that the delegates can implement?
Yeah, so Jay, I'm still a very much Indian. I still, after 23 years of living here, I still hold an Indian passport. I've never given Indian passport up. I'm not a Canadian citizen. And Canada has been kind. Without me having Indian citizenship, they still elected me to be president of their society here. And they made me head of the department. So I'm grateful. I think what we need to do, Jay, is sometimes when you see a big mountain in front of you, which is, oh, I've heard this great talk about the British Columbia surveillance program. They have a statewide program. How are we going to get the same program in Karnataka or India? That's a big task, as we know, with India. But what we can is, each of us, is start in our own clinics. As we showed in our own clinic, by chatting with people, by talking to educating therapists, educating pediatricians, family doctors, we have improved early referral. But the big challenge in India that I find is not just case identification and referral, is actually having resources to be able to manage them, right? I mean, because patients have to pay for themselves, and these interventions cost a lot of money. So that, I think, is where I'm hoping. I don't know if things like these are covered in our registry and others, and also figuring out those centers of excellence, because none of this is urgent, right? I mean, this is a planned follow-up and a planned surgery. So we need to have some centers of excellence where there are resources, there are teams that are able to carry out those. Because identifying is one thing, but being able to manage them is a whole other ball game, which I think is where, like, for example, in Tirupati for birth, there are a lot of resources. They were doing a lot of surgery. And then, sometimes politics get in the way. And recently, when I visited last year, they were doing a lot less children's orthopedic surgery than they used to. Now they have a new, Dr. Jagdish has come back as a director, and he's reinstituting a lot of the pediatric programs, but really figuring out those kind of opportunities. I know you, Jay, have a lot of interest, and you do a lot of charity work, and you do a lot with children with cerebral palsy. So it's really identifying those opportunities once patients are identified for interventions. But education, this is where I think partners like UNICEF come in the way, because they have a really good network of educating our primary care providers, who are sometimes, like our midwives, our PHCs, our primary health centers, and others, having these, hip surveillance guidelines, or educating people and say, hey, if you see a child that can't walk, that's in a wheelchair, there's a 90% chance that that child could have a hip problem. And that needs to have some X-ray. X-rays are not that expensive these days. So I would say India, our challenge is twofold. One is screening and identification, early referral. Second is, once the patient is referred, how are we going to take care of them?
So
but the fact
thank you.
Yeah, IACP is thinking about this, developed a care pathway, brought people here now to talk, is a testament already that this is a very engaged group that want to help and that want to change things.
So actually, we maxed out on 100 delegates, and many delegates will not have had the opportunity to listen to your talk, but most of the IACP talks are on YouTube. So we will send out a link to those who have missed out so that they can catch up on the lecture. We have one question, in fact, a series of questions. Can equinus lead to dislocation?
Yeah, equinus is the most common cause, but not necessarily. But that being said, it's called long leg dysplasia. So in a hemiplegic, if they have equinus, if that leg ends up being longer, so it puts a pressure to continue to push the hip out. So I would say equinus on its own, no. But if you have asymmetry, and if that leg happens to be a lot longer, that means your pelvis is up and it pushes the leg into adduction, and it can continue to make it worse. Second, I'm reading here, pelvic obliquity, that's very, very important. Anytime you see a pelvic obliquity, that means you really have to rule out, do they have scoliosis? So the minute we see pelvic obliquity, we either follow them very closely, or we don't discharge them from our surveillance program, even if they are a lower GMFCS level. And the third is leg length discrepancy can cause, yes, for sure. As I said, the longer leg goes into adduction, and that can actually push the hip out. Is it unilateral or bilateral? That is another great question. And it usually happens both hips. But when I myself used to do unilateral surgery, and then the other hip would go out quite quickly. So what we do now is prophylactically, you operate on the other hip as well based on their age. If they're old enough, I do surgery on both sides. Windswept deformity in spine is the most common problem. I would say not necessarily just with supine. I mean, that is probably the most common position that people lie down if they have bad knee flexion contractures, or if they have internal rotation on one side, or asymmetry. That's the most common position. But you can see people in a frog position where instead of having hips going out at the back, they actually come out at the front. I've seen fully dislocated hips in the front with bad knee flexion contractures and they're in a frog position. The other thing you can have is if they've got bad knee flexion contractures, they're in W. That means knees are pointing forward. In those cases, the hips are completely out at the back. So pay attention to knee. That's not well talked about, but something that we're looking at and studying now. Knee flexion contractures impact the hip position and make the hip subluxation worse. Can tummy timing help and rolling on both sides help? I would say not necessarily the positioning as such. People have not figured that would slow down the progression as such. But in general, keeping the hips abducted with a pillow in between or whatever, making sure that the hips are not adducted or crisscross, I think would be really helpful. Can sitting on a horse? Yes, because you are keeping the hips in an abducted position can help, because if they're in a wheelchair, we put a pommel between the legs so that we can keep the hips apart.
So if there are any other questions, participants can just unmute themselves.
So there's one question in the chat. Is there any relationship between hip dysplasia and tibial torsion? Where to correct?
Sorry, Jay?
There was a question about whether tibial torsion,
Yeah.
problems with tibial torsion can cause hip dysplasia.
The tibial torsion, I don't think so. Tibial torsion alone, and but the femoral rotation can impact if there is a lot of anteversion and those hips are subluxed, and we actually correct that with surgery. At the same time, if we correct too much of the anteversion, sometimes we have dislocated hips out at the back. So it's not tibial torsion alone, not that I know of.
Dr. Kishore,
So-
I have a question. Yeah, excuse me. I have a question, sir. So for children who are not medically fit for surgery, what do you recommend in case if they have subluxation and children who have severe windswept deformity? What would your recommendation be if they're not fit for surgery?
Sorry, can you repeat the question, Vidya? Sorry.
Yes, sir. Like for children who are in GMFCS level 5 and they have severe windswept deformity, and I suspect they definitely have bilateral hip subluxation, but they're not fit for surgery. That is what the authors say. So what would be your recommendation if they are not fit for surgery? Any other recommendation?
Yeah, I think it's really how do we manage pain? If they're not fit for surgery, and you probably want to slow down the progression for it to be fully dislocated if you can help it. And if they do develop pain, how do we manage that? Sometimes a local and steroid injection helps to keep the pain for a short period of time, or doing lesser interventions. So we have done where either femoral excision if when they become really painful, if you're able to do that, but a huge reconstruction and the follow-up that's required with that is a big undertaking for kids that are not medically fit. But really, it is slowing down the progression if you're able to. If you know that you're not going to be able to do surgery, what can we do positioning-wise so that we can teach them hip health is what I call.
We have one more question on the chat, if you can read it.
Can a child of 2 years of age, GMFCS2, have bilateral? It's highly unlikely for GMFCS2, but we have seen some odd ones where they are they have sublux tips, but that could be a cerebral palsy with DDH, because the development dysplasia of the hip that happens in population, and the percentage should be no different whether they have cerebral palsy or not. And we do see sometimes dislocated hips that are like development dysplasia of the hip in children with cerebral palsy.
So things like there's a comment that in patient who is not fit for major surgery, they can do some pain relieving measures, such as fasciculotomy of the obturator nerve, etc. But really, the point I think is to prevent these hips from dislocating, to identify them early, and to keep educating every member of the team from the bottom up, to think about hip surveillance, because in my experience, I see many children who are 7, 8, 9 years of age, GMFCS level 3 and 4, who have never had a hip X-ray in their life. So that is our starting point now, is to identify these children, to think about hip surveillance and to perform that hip X-ray. I think that is, a good starting point for all the delegates who are here today, is perform that hip X-ray, because clinical examination itself is not very specific or even sensitive for picking up hip displacement. And I think if we perform more hip X-rays, we will at least pick up these conditions at an earlier stage. So if there are no other questions, I would like to really wholeheartedly thank Professor Kishore Mulpuri for his excellent review of how to do a hip surveillance program. You've really covered those things that are not typically covered. We are extremely grateful to you. And I think IACP is the perfect platform for us to implement this in our practice. I would like to hand over to Dr. Mallikarjun